in over 70 early to late stage clinical trials studying common retinal diseases such as dry and wet macular degeneration. Dr. Ashabak presents data internationally and is a regular abstract presenter at the American Society of Retina Specialists, American Academy of Ophthalmology, and the Association for Research in Vision in Ophthalmology. Dr. Ashabak will talk today about the basics of macular degeneration and what can be done to improve your vision, and particularly what can be done in the future. So it's now my pleasure to introduce to you Dr. David Ashabak.
Thank you, Lauren. It was a kind introduction. I appreciate it. I'm David Ashabak. It's nice to see everyone here. This is an incredible turnout. I got here at 8:30 and everyone had eaten breakfast except for me. So you guys all beat me to it. That's fantastic. I practice at Retina Ventures Associates of Florida, which is the largest retina group in West Florida, the largest independent retina group in all of Florida. And I run the research part of that group. It's something that I've been very excited about since training, and we can talk about pipeline research and what's coming and answer questions about that when we're done with the slides. I have a lot of slides and a lot of time. I am gapped by no-tau vision. I think after we talk about diabetes, we're going to have a video from them, and then we'll go back into macular degeneration. We're going to start with diabetes. Diabetes is the original pandemic. The incidence and prevalence of diabetes in the United States is increasing, probably for a variety of reasons related to lifestyle, genetics, things like that. But we're going to have a diabetic country with about 1 in 3 to 5 patients projected to be diabetic by 2050. This was a projection done in 2010, and it seems to be on target. 100 million Americans by 2050, about 25 to 35% of the country is projected to have some form of diabetes. Why is this important? Diabetes is the 6th leading cause of death in the U.S. It's the leading cause of blindness in folks less than 74. I don't see many people less than 74 in this room, so you probably don't have to worry as much. But your children who may be diabetic and grandchildren have to worry. It's the leading cause of kidney failure, leading cause of non-traumatic amputation, and it costs a fortune, hundreds of billions of dollars in diabetes care. Diabetes myths. These are non-truisms that it only occurs in obese people, that not taking medications to control the disease means the disease is less serious, having type 2 is better than type 1, type 2 is non-hereditary, type 2 patients do not go blind, and I will know if diabetes has damaged my eyes because I have symptoms. All of those are untrue. We will dispel all of that and talk about what is true about diabetes. The most critical thing, the one thing to take away from this presentation for anyone with diabetes or anyone who has a loved one with diabetes is good vision on the eye chart or daily life does not mean the eyes are healthy. We're going to talk about this a couple of times in this brief talk on diabetes, but the most common symptom of advancing diabetic retinopathy is no symptoms until you reach a cliff. Diabetic retinopathy and all of these words on this information-rich slide is basically damage to the smallest blood vessels in the body. The hyperglycemia, the high sugar, poisons the walls of the smallest blood vessels in the body. The 3 places that you have the smallest blood vessels: the back of the eyes, kidneys, tips of the toes, and fingers. Those are the parts that are most susceptible to hyperglycemia, which is why amputations, dialysis, and loss of vision all go together, lower extremity amputations especially. Diabetic retinopathy is the leading cause of severe permanent vision loss in working-age Americans. Most patients with sight-threatening diabetic retinopathy have good vision until they don't. It gets worse, and you don't know until you fall off the cliff, and at that point, there's very little reserve left in the eye. This is an example of what happens to a patient who was 20/20 before they had this large hemorrhage in the inside their eye from proliferative diabetic retinopathy, which progressed asymptomatically. So get the eyes checked. It's very important to realize that diabetic retinopathy is preventable with lifestyle changes, improved control of sugar, medical management, medications. And secondly, it's treatable. So the most important thing to do when you have a patient or a loved one or a family member or you are someone suffering from diabetes is get the eyes checked. Just get them checked. Should not be with a retina specialist like me initially. It should be with a general eye care provider, an optometrist, a general ophthalmologist. As long as they have experience in treating patients with diabetes and they have the technology to get the appropriate imaging, a general eye care provider is the place to start to get your general diabetes eye exams. And we can do a great job preventing diabetes. People with diabetes don't get eye exams, and it's multifactorial as to why. It's cost, it's access, it's lack of education. All these things reduce the proportion of people who get eye exams who have diabetes from the ideal, which would be everyone, to some number lower than that. Type 2 diabetes leads to diabetic retinopathy probably in a greater number of patients than type 1, even though type 1 diabetic patients, people living with diabetes from childhood get diabetic retinopathy younger. Most diabetic retinopathy is from the much larger population of type 2 diabetes patients. Patients with long disease duration, high sugars, A1Cs that are poorly controlled, or glucose that doesn't have time in range, glucose levels that are fluctuating, brittle diabetics, poorly controlled hypertension, all go together to increase the risk of patients with diabetes. See this? This is a continuous glucose monitor, a CGM. These have changed the world. These allow patients with diabetes to have more time in range, improved A1Cs. This is a technology which goes hand in glove with your portable digital technology to give you a tracing of your glycemic levels throughout the day. These devices have improved the A1C as much as adding insulin in some studies. These are incredible devices for the motivated patient with diabetes. So if you don't have a continuous glucose monitor and you're a patient with diabetes that is uncontrolled, this is a great piece of technology to add. I'm not advocating for any specific one. I'm not going to advocate for any specific commercial product as a speaker here at the MDA, but for the technology itself, I'm advocating for. I think that getting a continuous glucose monitor, if you are an uncontrolled diabetic, is great. If you're controlled on whatever your medication is, your A1C is 6.2 or whatever, you don't need to add in a continuous glucose monitor, but if you can't get your A1C below 8 or 8.5 or whatever your doctor says you ought to be at, this is a great way to try to do it. Is there a link between blood sugar and age-related macular degeneration, which is a different diagnosis from diabetes? The short answer is yes. There's data showing that the increased intake of processed carbohydrates, all the delicious things that I love to eat but don't eat much anymore, like cinnamon buns and pancakes and bagels and all that stuff, is probably related to increasing your risk of macular degeneration to some extent, even though it truly and more dramatically increases your risk of developing diabetes and diabetic retinopathy. Patients who have diabetes are unaware, typically, that they should get eye exams and what the frequency of those eye exams should be. It's actually super duper easy. When you have a diagnosis of diabetes, you should get an eye exam no less frequently than once a year. That's all you gotta remember. Once a year. If you do get a diagnosis of diabetic retinopathy, the person taking care of your diabetic retinopathy may recommend eye exams more often than once a year, but that's not for you to remember. That's for the doctor looking at your eyes for the diabetes to recommend. At least once a year, if you have diabetes, for an eye exam for diabetic retinopathy. Again, this deck is emphasizing this because it's so true. The most common symptom of progressive diabetic retinopathy is no symptoms. It's all good until it isn't. Get the eyes checked. You can identify the disease earlier and make the appropriate changes either in the diabetes management or treat the eye if the eye has to be treated. This is We're going to have a couple of creepy eye injection pictures. The standby for treating patients with diabetic eye disease is injections in the eye. We also still use laser. The injections are not painful. They're incredibly safe. They're an intervention. There is risk to intervention. There's a risk to driving to the Macular Degeneration Association meeting. All of us are running the risk of getting hit by a bus and not making it home. Life is full of risks, but risks are balanced by the benefits of accepting those risks. And in diabetic retinopathy and in macular degeneration, which we'll talk about, the standby of treatment is intravitreal injections, and we're working on making these better, longer lasting, more potent, more beneficial for patients than they already are. And compared to when I started training 20 years ago, these have changed the world for patients' outcomes. The critical message is almost all severe vision loss from diabetes can be prevented if every patient with diabetes had access to eye care and went and got their eye care and then had access to good medical care and was compliant with their medical care. We could prevent not just vision loss, but many of the complications of diabetes. Patients with diabetes can live normal life expectancies with good sugar control. And vision loss from diabetes is preventable with good sugar control, good blood pressure control, and treatment in the eye with those medications and or laser and or surgery when it's needed. It is a treatable condition, which is incredible, because diabetes is a complicated condition. The other common eye problems which are increased in incidence when diabetes is not controlled include pretty much all the common eye diagnoses you can think of. Cataract, glaucoma, and dry eye are all more prevalent in patients who have uncontrolled diabetes. And what you need to do is find a great eye doctor. How do you find a great eye doctor? Not necessarily by looking at the guy talking at the Macular Degeneration Association. I think I'm a pretty good eye doctor, but I'm not the eye doctor that most patients with diabetes or macular degeneration needs. What you need to do is find a board-certified optometrist or ophthalmologist. Step number one, are they board certified? Do they maintain board certification? If the answer is yes, that's a good start. If someone lost their board certification, I'd probably look elsewhere. Ask your endocrinologist. If you're looking for a diabetologist, eye doctor, ask your endocrinologist who they work with, who sees a lot of patients with diabetes. Ask your eye doctors when you call them if they take care of patients with diabetes and do medical eye exams. Going to Pearl Vision in the mall and not getting dilated and not getting any pictures is not a medical eye exam. That's a retail spectacle exam, which is important. I don't write spectacles in my practice, and you gotta go get glasses, you gotta get spectacles and contact lenses, but it's not a medical eye exam. So ask your eye doctor, whether they're an optometrist or an ophthalmologist, they do medical eye exams in patients with diabetes. And the last important thing is, do they have modern imaging technology, meaning OCT, which we'll talk about, and color fundus photography. Board certified, recommended by your primary care doctor or endocrinologist, routinely do medical eye exams, and have the appropriate technology to do medical eye exams. And that's the combination. It's a couple of things, but it's an important couple of things. So make sure you or your loved one with diabetes gets a diabetic eye exam at least once a year. More frequent eye exams if recommended by the optometrist or ophthalmologist who does the diabetic eye exam. And treatment. Take care of the diabetes in the body, in the eyes. The vision loss is preventable, the amputations are preventable, the dialysis is preventable. All of this stuff is preventable, but it does take a little bit of effort and a little bit of work on everybody's part, including your doctor's parts. There are a lot of resources. Diabetes is an incredibly well-supported condition. The American Diabetes Association is probably the best all-around diabetes association in the United States. DiabetesIncontrol.com and DLife.com is a little kind of a youthful demographic in DLife.com, but there's a lot of support and a lot of ways you can get educated on diabetes and kind of learn more if you need to. That's the end of the first talk. It's short. We're going to spend a lot more time on macular degeneration. We'll have Q&A with me at the end, so let's hold diabetes questions until the end, and we will go on to our next speaker, who is virtual. All right.
our vision. We used
Thank you so much for the introduction. The Nodal Vision Monitoring Center is proud to partner with the Macular Degeneration Association, and I appreciate the opportunity to speak to you all today. It is such a privilege to be able to do so. I would like to further discuss understanding the importance of detecting wet AMD early and how you can play a role in protecting your vision. Oracy Home is FDA cleared and Medicare covered, and it is prescribed by your eye care professional when appropriate, depending on your level of vision and your stage of AMD. It is a form of personalized medicine with the Oracy Home device used at home in between your regular eye exams. The device is a metamorphopsia detector, which just means that it detects visual distortions in AMD. AMD is a leading cause of severe central vision loss in people over the age of 50 years in the United States. I'm going to share with you the information you need to get informed and take charge of your vision. AMD is a chronic condition, meaning it does not resolve or go away, and it tends to progress or worsen over time. AMD progresses through three main stages: early, intermediate, and advanced stages. The advanced stage can be either advanced dry or wet AMD. Early and intermediate AMD are the slower changing, earlier form of the disease. However, once there's progression from the early to the intermediate stage, this puts one at risk for developing wet AMD. Not everyone with AMD progresses to wet AMD. However, those who do have a significant risk of vision loss, especially if not caught early. Wet AMD, which again is one of the advanced stages of the disease, can occur suddenly and without warning. AMD affects an area of the retina called the macula, which is responsible for detailed central vision used for activities like reading, driving, and seeing faces clearly. In the early and intermediate stages of dry AMD, changes occur in the cells of the macula and drusen, which are deposits built up in this area. These changes may induce blurry vision, such as difficulty seeing sharp details both up close and from a distance. Again, early and intermediate dry AMD are the slower forms of the disease, with changes you may not notice. Over time, the size and the number of the deposits in the macula can increase, which increases your risk of developing the more sight-threatening wet AMD. Intermediate dry AMD can suddenly change to wet AMD without advance notice. If you convert to wet AMD, abnormal blood vessels grow under and into the retina in the macula area. These blood vessels leak fluid and can sometimes bleed without any warning. You may not notice changes until significant vision loss has occurred. If you convert to wet AMD, significant vision loss can be rapid and severe. Symptoms of wet AMD include distortion, where straight lines begin to look wavy, dark spots or spots in the center of your vision, and generalized blurry vision can also be a symptom that patients may experience, as seen here on the screen. The good news is there are effective treatments for wet AMD. However, these treatments are most effective when administered early on, often before symptoms are noticed and vision loss has occurred. These treatments can halt or slow the progression of wet AMD, but cannot restore vision that has already been lost. Once the wet disease starts, it tends to continue to advance until you receive treatment. Irreversible damage can occur within days to weeks and often before symptoms are noticed. But how early is early detection? Once symptoms of visual impairment are noticed, like wavy lines or dark spots, vision loss may have already occurred. The earlier you catch wet AMD, the better chance you have of preserving your vision and your independence. So it is important to remember, wet AMD treatments are effective, but they are most effective when the disease is caught early. 4C Home is an early warning system for your eyes. You use this device at home in between your regular eye exams. It helps your doctor detect wet AMD often before visual changes have occurred. But how does it work? You take a simple daily test that checks for changes in your vision. The test takes a few minutes per eye per day. Data from each test is sent to your eye doctor as well as the Nodal Vision Monitoring Center, the provider of 4C Home. If a change in your test score is detected, the monitoring center alerts your doctor. Your doctor's office will determine the best course of action, which typically includes scheduling a follow-up visit. Testing with 4C Home is easy. Simply turn the device on and look into the viewfinder to begin testing. Take an easy test where a bump briefly appears and then disappears. Use the mouse provided to click where the bump appeared and then return to the center dot. Data from each test are sent to the Nodal Vision Monitoring Center for evaluation and also provided to your eye doctor. Regular at-home monitoring is like brushing your teeth. It's a good habit you do every day to help preserve vision. Our team will be sure to verify your insurance benefits and discuss those benefits with you prior to your acceptance of the device and getting started with the program. The Medicare-covered 4C Home is billed as a monthly service fee. There are low out-of-pocket costs for traditional Medicare patients, and depending on your coverage, you may pay nothing at all. If you do not have a secondary supplemental plan, you will pay around $15 per month after your Medicare fee-for-service deductible is met. 4C Home allows you to take a proactive approach to protect your vision. After the Nodal Vision Monitoring Center receives a referral from your doctor, we will answer any questions, verify coverage, and ship your device. Once you receive the device, the Nodal Vision Monitoring Center will walk you through setup and training. Once you begin testing, you and your doctor will continue to receive feedback from the Nodal Vision Monitoring Center. There are no obligations to enroll in the program, and you can cancel at any time. Managing your AMD with the 4C Home Monitoring Program can lead to significantly better outcomes. A major study showed that wet AMD is detected when the average vision is 20/83 and patients monitored using only standard of care, which means you wouldn't be able to see below the top 2 or 3 lines on a vision chart in your doctor's office. Numerous studies have shown that adding 4C Home to a doctor's standard care plan can help detect wet AMD while patients still have 20/40 or better vision. This is the vision required for unrestricted driving in many states. Hopefully I've given you some information on how you can take an active role in monitoring your eyes to give you the best visual outcome as you embark upon or continue your AMD journey. Thank you so much for your time today, and you may visit our website at 4chome.com or scan the QR code on the screen. Thank you.
Okay. I'd now like to re-present Dr. Reichenbaum. He's going to give a brief overview of macular degeneration in different types. He's going to cover new research, treatments, and innovations. And he's going to provide a summary of geographic activity, available treatments, research, and emerging technologies. So it's now my pleasure to represent Dr. Eisenberg.
For that summary of the 4C home. I'm happy to answer questions on that. I can address that from a clinical perspective as well. This is a lot of slides, but I'm going to move through them pretty fast so we can get to Q&A. Our stop is around 10:30, I think, so we have an hour. Is that correct? Am I on schedule there? Yeah, stop is about 10:35, something like that. So I think we have about an hour and change to go through this, and we'll try to devote some time to Q&A. MacularHope.org, that's the website for the Macular Degeneration Association. Just so you know, check it out if you haven't already. The macula. I usually start my new patient visits for macular diseases talking about eye anatomy. This is a cross-section of an eye, a human eye, higher primate eye, whatever you want to call it, a large mammal eye. They all look similar. The macula is in the middle of the back of the eye. The eye is like a box camera. It's, I like talking to an audience that's old enough to know what a box camera is. I talk to my young patients with diabetes, and everyone thinks a camera comes in a phone. It doesn't. The camera is like a box. And the box in the eye camera is full of the gooey vitreous, which is really mostly water, and it's clear, optically clear essentially. There's two lenses, just like a regular camera. There's an external lens, a cornea. There's an internal lens, which turns into a cataract and gets taken out in the cataract surgery, and a clear lens gets put back. Then you have the box. Instead of being full of air, it's full of clear, gooey stuff, vitreous. And you have the macula, which is the middle of the retina. The retina is the film of the camera. It lines the back of the box. And the high definition part of the film is the macula. It's where everything is focused. When you're appropriately focused, all of your images coming in are focused on the macula. But to see clearly, you need to have good film in the camera, or you get a blurry picture, even if your lenses are good. Here's the box camera analogy. And this is talking about the retina. These are clinical images of the retina. Top left, that's a larger retinal view. Bottom right, that's a more magnified retinal view. The macula, it's a little bit more pigmented, it's a little bit more orange when you look at it. When you look at retinal images, you see this object to the left in these pictures of the macula. That's the optic disc. That's the thing that your attention is drawn to when you see a clinical image of the retina, but that's not actually the macula. You think of the optic disc as like the tip of the telephone wire to the brain. If you go back to the eye anatomy, you can kind of see the telephone wire sticking out of the back of the camera there. It doesn't actually do the seeing, it does the transmitting of the signal to the brain. About a third of your brain is devoted to processing vision. A whole lot of the brain processes vision. The occipital cortex processes vision. It's where the visual cortex processes vision, and it's pretty large if you look at brains. What is macular degeneration? Macular degeneration is a frightening diagnosis. It can be anxiety-provoking. There's a lot of support, and there's a lot better treatment than there was 20 years ago. And there's better treatments to come, better things to come. We'll talk a little bit about that. It's the most common cause of legal blindness in people over the age of 65, and there's a whole range of severity. If you're told you have macular degeneration, it can be anything from something extremely mild that will never meaningfully affect your vision to something that renders people essentially non-functional visually. There's a gigantic spectrum of disease. It's like heart disease. You can have heart disease where you take a cholesterol pill. I take a cholesterol pill. I take Crestor, and I take Repatha for my high cholesterol-mediated heart disease, but I don't have a pacemaker and a stent and a bypass, which is also heart disease. So just like heart disease, there's a range of severity of macular degeneration. Patient characteristics. Age, it's age-related. It used to be called senile macular degeneration. That term has sunset. It's now age-related macular degeneration. It's age 60 or older. Family history and genetics are tremendous. tremendously genetically driven, like many other ocular and non-ocular conditions. Women are generally more likely to get it, and I'm not sure if that's more of a prevalence issue. I think women survive longer than men. That's part of the reason that women are more likely to be the macular degeneration patients. It is more common in lightly pigmented people. The more pigmented you are, the less likely you are to have macular degeneration. African Americans, Asian origin Americans do have macular diseases, but they're different than age-related macular degeneration. Most important environmental risk factor, and we'll get back to it again and again, is smoking, smoking, smoking. I don't care what vitamins you take, I don't care how much salmon you eat, I don't care how much exercise you're doing if you're smoking. Smoking is more important than everything else put back together for macular degeneration risk. Weakest risk factor is ultraviolet light exposure. It's probably not great to have unfiltered ultraviolet light exposure your whole life, but most of us don't sit there and stare at ultraviolet light even when we're young, but that's the weakest risk factor. Ultraviolet protection is good, not as important as everything else for lifestyle modification. What do we know about EMD? What's better, the dry kind or the wet kind? That's a nuanced question. We can get into that. A lot of folks know somebody who's lost vision or is blind from macular degeneration. It's not total blindness. No one with pure macular degeneration goes totally blind, like the lights are out. Blindness from macular degeneration is central blindness. It is the middle of the vision being blurry, like end-stage macular degeneration is like having a dime over the middle of your eye all the time that moves around with your eye, and you can't get around the dime over your eye. If you have that in both eyes, you can't see real well because you got this dime covering the middle of your vision in both eyes, which renders you functionally blind and legally blind, but not blind like the lights are going out. If you have macular degeneration and it's severe, there's probably somebody in the family who has vision loss, a parent or sibling or an aunt or an uncle, very genetically driven. All macular degeneration starts out as dry. Everyone with the correct diagnosis of wet age-related macular degeneration had preceding dry macular degeneration of some severity. Drusen are what we see when we look in, and we'll see examples of drusen. Drusen are a finding on an eye exam that are the most common feature associated with macular degeneration. Not all drusen are macular degeneration, but most drusen are macular degeneration. Dry may progress to wet, and dry macular degeneration is considered advanced when you have so many drusen and changes in the eye that you get thinning and atrophy. And we'll talk about geographic atrophy since there's a lot of new, both commercial and pipeline technology related to geographic atrophy. Geographic atrophy, or the advanced form of dry macular degeneration, is probably still the largest unmet need in retina care. We're still looking for something really good for dry macular degeneration with geographic atrophy. Of course, we're trying to get better with our treatments for wet macular degeneration. How common is macular degeneration? Super common. Leading cause of blindness in older folks. 80 or 90% of cases are dry, 10 to 20% are wet. 11 million people in the US have macular degeneration. Not nearly as many as diabetes, you'll notice. It's been projected to be a third of the population being diabetic, but in the elderly population, the prevalence of macular degeneration, the elderly Caucasian population, the prevalence is fairly substantial. 1.1 million people have wet then, and there are about 250,000 legally blind people in the US. Geographic atrophy affects just as many people worldwide as wet macular degeneration, but it's been less discussed because there have not been treatments for it until very recently, and we're spending a lot of effort looking for better treatments for geographic atrophy. Glaucoma. What's more common, glaucoma or macular degeneration? Macular degeneration is actually more common, but glaucoma is more talked about because there's been a lot of treatment for glaucoma for a very long time. And macular degeneration has that big range of severity. Like macular degeneration with just drusen is extremely common. very minimal from a functional standpoint, doesn't need treatment, but if you have glaucoma, you get treatment usually, you get an eye drop. Genetics we know is huge. These are examples on the right of vision in people with macular degeneration. You get this spot over your vision, you get distortion. It's a range of severity. You can have advanced macular degeneration and still be able to see 20/20, but maybe there's a spot near the center that's very distorted. You can have macular degeneration, which is advanced, and you can see count fingers because the spot that's distorted or absent is large and in the middle. The best predictor of how someone's going to perform clinically with wet macular degeneration is the level of vision when they start treatment. It's much easier to preserve vision than restore vision in wet macular degeneration. Probably true for dry as well, but dry is a different beast that we know less about, the geographic atrophy. The wet degeneration we know a lot about. We know the best predictor of your outcome is how good your vision is when the wet degeneration is diagnosed. This is a beautiful, large, semi-processed color picture of drusen. These little guys are the drusens. This is a lot of drusen. These are medium to large drusen. They often come with pigmentary changes. This is clumping of the pigment and atrophy of the pigment around it. Typically, when you look at a normal eye, you want to see a nice, smooth, orange reflex looking back at you. But that's a nice picture of drusen. Drusen on the left, they're over here. Geographic atrophy on the right. The drusen are not visible anymore in this particular eye. They become less visible or invisible when they lead to geographic atrophy. That's center involving geographic atrophy. OCT is a test that you may receive frequently. Those previous images were color fundus photographs, like color pictures. You can think of those previous pictures as like a family photo, like you're standing up and someone takes a picture. The eye's dilated, sitting in front of the camera, you take a picture. OCTs, I think of OCTs like slices, like a CAT scanner. And the OCTs are like if you take the macula and you look at it like a birthday cake. You look at the birthday cake, you're looking down at the birthday cake, and then you slice up the birthday cake, and then you take a look at each slice on the side, and you see the layers of the birthday cake. And that's what the OCT shows us, is layers. The OCT at the top here has these lumps and bumps under it, which are the cross sections, the drusen in the layers of the birthday cake. You could think of that as like a couple of pecans or walnuts at the bottom of the birthday cake slice. If you're thinking of it, if you're really into processed carbohydrates and you're following the birthday cake analogy, because I love birthday cake. Macular degeneration can progress within days. The progression is slow. For dry macular degeneration, if it converts to wet, the progression can be fast. You can wake up one morning and have a dark spot or distortion in the eye. If you do have a dark spot or distortion in an eye that has known macular degeneration, call your eye doctor. You don't have to call your eye doctor at 3 in the morning, but you want to see your eye doctor within a day or two of having the new onset distortion. You don't want to wait a month or two. Sometime in the next couple of days is good. If you call your eye doctor and they won't see you for a month or two, find a new eye doctor. We live in a very, very medical area. There are eye doctors on every street corner. Find someone to see you if there's a dramatic change in your central vision. Can macular degeneration be cured? It cannot be cured, but it can be treated, which we'll talk about. Will I eventually go blind? Not likely with treatment from wet macular degeneration. Wet macular degeneration with treatment, early and appropriate treatment, can preserve vision for a long time. Can I keep the vision I have now? The answer is mostly. The answer here, the deck says yes. The answer is mostly. The vision does tend to decrease even with treatment over time, but very slowly compared to untreated wet macular degeneration. Dry macular degeneration with geographic atrophy is a little bit of a different animal. Probably tougher to preserve vision with geographic atrophy than with wet macular degeneration. What are practical treatments? What is good? Before you have wet macular degeneration, quit smoking, quit smoking, quit smoking, and everything else. What is everything else? Micronutrient supplementation, age-related eye disease supplements, we'll talk about that. Diet and exercise. I got up this morning, I went cycling because time is passing for all of us, Yes, that was a risk. I'm afraid I'll get hit by a car, but I also felt good, got my cardio in, and saw the sunrise. That was all good. Did not get hit by a car today, maybe tomorrow. To manage your systemic disease, keep your blood pressure low, keep your cholesterol low, and wear UV protection sunglasses when you're outside, starting as a child. You know, if we could undo all the mistakes we made as children, we'd all probably live longer and be healthier. So tell your grandkids and kids, don't smoke, wear your sunglasses. Again, smoking cessation is the first step. The vast majority of people who are smokers have never heard an eye doctor tell them to quit smoking. I'm here to change that. So is the Macular Degeneration Association. What should I be eating? This looks delicious. When I was 20, this didn't look delicious. This looks delicious. This is fatty fish on the left with dark leafy greens, things that people call the Mediterranean diet, omega-3 fatty acids, things rich in lutein and zeaxanthin. And on the right side, limited intake of red wine is probably reasonable for cardiovascular disease, macular disease. This does not mean a bottle of red wine. This means a 6-ounce or less glass of red wine on a regular basis is probably reasonable. And chocolate of that size. I know this is the fun side. I like this side of the picture better too. But this does look delicious. If I could have this for dinner 4 out of 7 nights a week, I'd be pretty happy and probably have a pretty healthy macula. Notice what's missing is one of my other favorite parts of this dinner, which is the bread. Do not eat the bread. That's the processed carbohydrate. You have enough carbohydrates here to probably be all that you need. Physical activity was well studied in something called the Beaver Dam study. The Beaver Dam study was a large population-based study that was started in the 1980s and published papers for a generation. As far as I know, the data collection from the Beaver Dam study is over, but it looked at multiple publications. This is one from 2006, and a second publication from 2015 that looked at activity. And the translation of the activity paper is that walking as little as 1 block per day cut the incidence of wet macular degeneration by 50%. You don't have to go cycling at dawn. You don't have to run a marathon. You don't have to go to the gym and lift 200 pounds. You do have to get up and do something. You got to get up and do something. You got to get the heart rate up a little bit. You got to do it on the regular, meaning at least 3 to 4 times a week. 1 block per day. Weather's getting nice. Get outside. It's good, easy public health stuff. There we go. Don't need to pump iron. Don't need to run marathons, but you do have to do something. And it feels really good, in addition to making you less likely to have macular degeneration. Managing dry macular degeneration, there are multiple brands of vitamins. I'm not a vitamin salesman, I'm a science salesman. I don't care what brand of vitamins you buy, as long as the vitamin says AREDS on it, or AREDS 2 on it somewhere. AREDS is Age-Related Eye Disease Study, which is a National Eye Institute-sponsored study looking at micronutrients in macular degeneration. The AREDS 2 is a more modern formula that doesn't have beta-carotene. The thinking there is that beta-carotene has a theoretic risk of increasing lung cancer in current smokers. So if you're a non-smoker and you haven't smoked in a year, it doesn't matter whether you're taking AREDS or AREDS 2 vitamins, but whatever you're taking, I don't care if it's Neiman Marcus's boutique vitamins or Costco's, buy the gross vitamins. As long as it says AREDS on it or AREDS 2, you're getting the right vitamins. Everything else probably doesn't matter as much. Home monitoring. Monitor your vision at home somehow. Either use an Amsler grid, some kind of routine grid-like object like tiles or curtains or Venetian blinds, or new technology like the 4C home device. Monitor your vision at home. Monitor your vision at home. And if you see a change, let us know. Poor vision increases anxiety, increases depression. If you lose vision, it's normal to feel blue. People are sad when they lose vision, even in one eye. Do not feel weird about that. It is a normal feeling of loss. Poor vision from late detection can lead to functional disability and the subsequent anxiety and depression that's associated with functional disability. This is an Amsler grid. This is kind of a washed out picture, but a normal Amsler is on the left. The middle is a slightly abnormal Amsler, but it may not be performed correctly, so it may seem normal, and the right is a grossly abnormal Amsler. If you decide to do an Amsler grid instead of Instead of other types of home monitoring, make sure you're doing it right, meaning cover each eye and look at the dot in the center. Try to practice. Your technician at your eye doctor's office will help you learn how to do an Amsler grid. We probably have representatives from the Macular Degeneration Association who can help you learn to do an Amsler grid, but it's only valuable if it's done correctly. How often should you do an Amsler grid? I tell my patients with dry macular degeneration to look at it once or twice a week. Tell people to look at it every day and they'll never look at it. Tell people to look at it once a year and they'll forget to look at it. Once or twice a week, I think, is a reasonable ask. This is the 4C home device that you heard all about. We can talk about this too. This is a new technology, relatively new technology. It's about 10 years old now, and it looks at a projected version of an Amsler grid, what's called a hyper acuity screen, like a very small visual field that's projected onto your eye. And it is probably better than an Amsler grid for detecting early disease in patients with intermediate macular degeneration. And it's something that's available by prescription from your ophthalmologist or optometrist. It does have a cost to it. There's a bit of a cumbersome aspect to all technology, but it is probably a superior type of central visual field test. Symptoms of wet macular degeneration are distortion in the middle. Most people come in to see the eye doctor around this level of wet macular degeneration. We'd like to move the needle to this level, earlier detection. This is a picture, I think you guys saw this picture in the no-towel vision talk, the 4C home talk. This is what happens under the retina. This is a magnification of the center part of the retina. What happens is you get breakdown of the barriers between where blood and vessels ought to be and where they ought not to be. And you get this leakage which causes the retina to swell. There are barriers in the body between where fluid and blood ought to be and where it ought to not be. And this is the breakdown of those barriers. This is again looking at the family photo, looking at the eye sitting in front of you, or looking at the top of the birthday cake, looking right at the surface. These are called en face photos. Left is basically normal. Right is a very large hemorrhage from wet macular degeneration. You can see the pre-existing drusen above it too, but it's dry to wet macular degeneration. The treatment again is anti-angiogenic. These are we have just to play. They're going to play us. These are creepy videos of eye injections, so don't watch them if you don't want to. But the idea is to see that this is tolerable. I know that the eye is kind of Halloween-y. You know, the eye is sensitive. You get dust in your eye, it feels bad. We do these with anesthesia. We take care, at least in our practice, we try to provide a variety of anesthetic techniques. There are a variety of medications that are injected intravitreally. The biggest risk of the injection is a risk of infection. True with an injection anywhere in the body, the risk is about 1 in every 5,000 or 6,000 injections, so the risk is present, but the risk is low. There are a variety of medications injected intravitreally inside the eye for wet macular degeneration. They go by the names of Avastin, Lucentis, Eylea, Eylea HD, Vabysmo, Pavblu. There are a couple more. If you're a seasonal resident, welcome back to Florida. If you're a seasonal resident coming back to Florida. If you're a seasonal resident, the most important thing you can bring to your retina specialist and your other geography is the date of the last injection and what the name of the last injection was. That's all I need to know. I don't need to know anything else when somebody comes. It's nice when I get letters from other doctors, but letters don't always get transmitted for one reason or another. I try to send letters, and I know that doctors up north often get my letters, but sometimes don't. I don't know why they don't, but as a patient, your only homework is to know the date of your last injection, which eye your last injection was in. That's also helpful, and the name of the last injection. That's it. Very easy homework. Not everybody does well with wet macular degeneration treatment, especially folks who come in with poor vision. Anatomically, almost everyone gets better with the shots. We can stop the leakage with the shots, but we can't always bring back the vision. The key driver of seeing well is coming in with good vision. And if you don't see well, we have folks in the back, we have folks who represent low vision tools in the back, we have a lighthouse in the back there. The journey is not over because you've lost some central vision. You just have to use the vision that you've got better with the help of low vision technology, magnification, illumination, things like that. It's frustrating, it's hard, but it's not the end of the game if you haven't done well with wet macular degeneration treatment. This is talking about low vision. So conclusion of the general macular degeneration section is very common, starts out dry but can progress to wet. Early diagnosis and treatment is critical. You are not alone. There is support in this room, in this community, from your eye doctor, from your friends and family, from your vendors in the back. There's support for this, and there are resources. Let's talk about technology and innovation, then we'll do Q&A. What time is it? Oh good, it's only 5 minutes, and we'll have at least 20 minutes for Q&A, which is good. All right, clinical trials, new treatments, and innovations. I love innovation. I'm a clinical trialist. At our practice, we have one of the largest retina clinical trial programs in the entire United States by any metric you want to throw it in. And I love that part of what I do because I think we can do better. It's super gratifying to be part of the pipeline. We're going to start with new technology, then move to pipeline. Home monitoring is newish technology. Aside from the 4C Home, No Tau Vision has commercialized and is trying to make more available a home OCT machine, which is a really cool piece of technology. You can take an OCT home with you. Currently, it is commercial, but it is not covered by any insurance providers, and it's expensive. But it might be covered in the future. We're working on improving access to it with certain very long duration technologies for treatment. Like if you get a treatment once a year, let's say, instead of once a month, using a home OCT will help your eye doctor monitor that treatment without you coming to the office. So this is the direction that we want to go in, is less burdensome treatment, more sophisticated monitoring. Currently, the home OCT is essentially theoretical because it's unaffordable, but that might change in the future. We're working on it with the Center for Medicare and Medicaid Services. That's the 4C Home device that is commercially available. That's not for wet degeneration. That's for looking for the change to wet degeneration. The home OCT is for wet degeneration to follow the treatment response at home. So it's a different indication for the technology. Photobiomodulation, there's a lot of press about this. This is what goes by the trade name Valeda. This is light therapy for intermediate dry macular degeneration. This was FDA approved earlier this year. This was FDA approved in a very small study, only 120-ish patients. It's a very small data set. That data set is evolving. Our practice currently does not offer this, but we are thinking about it. We are looking at the technology, we are looking at the data. It's also cash pay right now, and if the data seems supportive, I would happily offer it. I'm not sure what to make of it yet. I'm trying to do critical thinking with it and see if it's worthwhile. It's very cool that we have some new data looking at photobiomodulation, which is non-laser light therapy for intermediate dry macular degeneration, based on a small study. What is geographic atrophy? We talked about this a bit. We can talk about it more. It's advanced dry macular degeneration. This is the ads you've been seeing. That's the guy, Henry Winkler, from the show that predates me. What's that show? Happy Days, yeah. Happy Days. See, perfect. They're so smart. They know who they're looking for. Everyone's at Happy Days, except for me, because I'm not a dry macular degeneration patient yet. I'm going to be 49 years old next week, so I'm not the right demographic, but I'm getting there, hopefully. Hopefully I'm getting there. At the bottom, what kind of car is that? Yes, that I knew. I like old cars. That's a Mustang, and that's another advertisement you've seen for geographic atrophy. I don't think 1965 Mustang convertibles were available in orange, but maybe it was repainted. And it's a high contrast color to help us see it when we don't have perfect maculas. These are the two drugs that are commercially available. Izervay on the lower left is associated with the Mustang. Syfovre on the lower right is associated with Henry Winkler. As far as marketing goes, these are both modulators of what we call complement modulation. They are first steps in dry macular degeneration management. It's amazing that we have drugs that do something for dry macular degeneration. They slow the growth of the geographic atrophy a little bit. I wish they were better. We all wish they were better, but they are an amazing start. They were both commercialized in 2023, and there's a robust pipeline looking for things that are better. This is Vabysmo, which is also known as faricimab. Its trade name is Vabysmo. Its generic name is faricimab. This is one of the two modern injectables. This is an injectable which is called a bispecific. It inhibits the protein that has been inhibited for 20 years with these drugs, plus a second protein. This is Eylea or aflibercept. Eylea is available in 2 different dosages now. There's 2 milligram and a new higher dose, 8 milligram. Eylea is a molecule we know a lot about. It was first FDA approved in 2011. The higher dose is relatively new. It was FDA approved in 2023, I think, or 22. Both the Vabysmo and the Eylea are intended to last longer, to increase the time between the injections. You don't see better with Vabysmo or Eylea than with the older injections, but you get fewer injections. That's the top line of the data, which is good. We as much as doctors like seeing patients, I would like to see all of my injection patients less. I know it's unpleasant to get injections in the eye. As easy as we try to make it, it'd be more fun to get an ice cream sundae. So we understand that. This is the port delivery system. This is a refillable device that's implanted. You can see it implanted on the eye to the right here, the eye in the middle. When you look up into the corner and you put a bright light into the eye, you can see it. This is a cool piece of technology. I've been involved in planting these investigationally since 2016. This was commercialized in 2022, withdrawn from the market, and reintroduced in 2024 with an improved construction. It's very cool because it only needs to be refilled every 6 to 9 months, maybe even less often than that. It's refilled in the office. It's put in the OR like a cataract surgery. It is an indwelling device, so we have to manage it a little bit differently than just getting injections, but patients really like it. It's a fascinating and very patient-centric way to have less frequent treatment. So it's an option for patients with wet macular degeneration. Now, I typically talk about it when folks are getting shots every 8 weeks or more often. If you're getting shots every 12 or 16 weeks, you probably don't need to go through a surgery and get an implant. If you're getting shots every 6 weeks and you're not real happy about it, it's reasonable to talk about an implant. We've done these at our site than almost anyone in the United States, or investigationally. Commercially, we've done some, and then with refills, I've done over 250 refills of this device. So we have a lot of experience with it, and it has its place. It has its place in the armamentarium. Is newer always better? Newer is not always better. That's why we do clinical trials. The good news about retina clinical trials is even if the newer is not better, patients do their best visually in clinical trials because everyone in wet macular degeneration clinical trials gets at least gold standard treatment, and if they're getting the investigative treatment, they're followed closely and switched or supplemented with gold standard treatment if the new stuff is not working. Clinical trials are a great way to get care because patients do very well in them. Patients get the red carpet rolled out. It's like flying first class. There's transportation provided. There's a coordinator that follows the care. There's stipends. There's all these different sort of VIP pieces of being in a clinical trial. The hard part is getting into one because the clinical trials are appropriately looking for a set of eyes that are basically all the same. And they want to look at from a couple of dozen to several thousand eyes that all basically look the same. So there's included and excluded criteria. But clinical trials are a great option for care. There are a lot of them. On clinicaltrials.gov, there are currently over 2,000 clinical trials for macular degeneration in varying stages and varying geographies. So there are a lot. And what does a clinical trial mean? There are a lot of words in clinical trials, including randomization, masking, double masking. Are they controlled? Are they multi-centered? Are they open label? What phase is the clinical trial? There are 4 phases of drug development. Can you be in a clinical trial? Do you want to be in a clinical trial? What can you expect from a clinical trial? All good questions, all beyond the scope of a presentation, but I'm happy to address them in Q&A. Talking about investigational therapy, we'll go to the big one first. Stem cell therapy. What is stem cell therapy? Stem cell therapy is taking an embryonic stem cell that's been processed and programming it to change into a cell that will work well. There are no late-stage clinical trials for stem cell therapy yet. The most advanced stem cell therapy trials are phase 2 clinical trials. We're enrolling one here at our site for geographic atrophy. They are very promising. There have been, in Florida especially, clinics providing stem cells as cash pay, quote unquote, research with some absolutely tragic results because it's uncontrolled research. If someone is selling you research that they're making you pay for, be very, very wary of it. Good research is funded either by industry or by government or by some kind of grant. And good research is controlled, good research is multi-centered, good research does not come out with a sales pitch that is too good to be true. So in South Florida, there were a number of clinics doing what they called stem cells, which was not good research in my opinion. And stem cells, this is what it basically looks like. You take a single cell and you can replicate that, and you program it to replicate or differentiate, and there's incredible promise in stem cells as regenerative therapy, but again, it's still early days. And if you're looking at a stem cell clinical trial program, be sure it's not one that's being advertised as a product and sold for a high cash price to patients who are desperate. What is gene therapy? Gene therapy is different from stem cell therapy. Gene therapy is further along. There are 2 wet macular degeneration gene therapy programs in phase 3 right now, which is the last phase of preclinical drug development. Gene therapy uses an adenoviral vector, a virus that's programmed with a gene cassette in it to change the cells in your eye to make a therapeutic protein. Basically what that means in simpler terms is you're using a genetic payload to make your eye make its own Eylea or Lucentis, make its own drug, which is a really cool idea. Because the idea with the shots right now is, it's like if you're thirsty. If you're thirsty, you have to go to the well, get in your car, you gotta go to the well and get water and drink the water. And every time you're thirsty, you gotta go to the well, you gotta drink the water, you go back home. And what this does, the gene therapy, the idea is it takes the well and it puts it in your house, which is a great idea. If it works well, it's going to have a place in treating patients with wet macular degeneration. We will see. These trials are currently enrolling. We should have top line from them in 2027. So everyone, the nice thing about clinical trials, it makes me optimistic that I'll survive at least to 2027 and learn about the results of the phase 3 trials. I think that's all we have on clinical trials, and it's only 10:07, so we have over 20 minutes for Q&A. What do you guys want to talk about? Yes?
I was on the NISMO.
Yes. Yes.
The grant stopped and I went back to FS.
Yep.
But I'm still able to do 4 months. Is that okay?
Yes, so it's a great question there. So this is it's an excellent question. It's a nuanced question. People who have given up their Medicare and have a Medicare Advantage plan have high co-pays, co-insurances, and deductibles, a high out-of-pocket responsibility. Never give up your original Medicare. Lesson number 1. If you have given it up and you have a Medicare Advantage plan, that copay, co-insurance, and deductible for these very expensive drugs, all of this stuff is really expensive. The very expensive drugs was covered by a grant called the Good Days Foundation. Good Days Foundation was funded mostly by pharma, like 99.5% by pharma. They were providing money to this grant foundation to pay for their own drugs, which is not a bad thing. It was good that pharma was helping defray the high cost of their own drugs. But the largest grant provider for that organization stopped giving the money. So the organization stopped having money to provide the copay support for these very expensive drugs. So a lot of patients who were on the expensive drugs and getting them at long interval doses, like our friend who asked the question, 4-month doses, were no longer able to afford those drugs and were switched to Avastin, which is the oldest, least expensive drug for macular degeneration. The question is, I've been switched to Avastin because of access problems related to the Good Days not having any funding. Can I still go 4 months? And the answer is, if you're going 4 months with a dry OCT, that's fine. I think that's good. As long as your OCT looks good and your vision is still good on the Avastin, it's great, and it's also saving the system a ton of money at the same time. So I have no problem with that. I would definitely let your eye doctor know if you have more symptoms, because we know the Avastin is less potent than the Vabysmo. But if the disease is quiet, you know, and with or without a good days issue, we can switch drugs. You know, you can't always expect the same result when you switch drugs, but in your case, it sounds like you're getting the same results. That's great. That's great. And I'm annoyed that there's less access for you in the absence of the Good Days funding, but I'm glad you're doing well on the drug that's fully covered. The Medicare Advantage plans typically fully cover Avastin, which is the oldest, least expensive, least potent drug. But that's the one that a lot of folks are switching to when the Good Days expires, or when the Good Days is. Does that answer the question? Good. It was a great question. Covered a lot of stuff in one way. Yes?
I was diagnosed with dry macular degeneration after going to an ophthalmologist and a retinal specialist with red flashes on my eyes and sponsons on my eyes. So I was put on a red tube. And I'm wondering if you something like that is routine or other
Great question. The question was, I have red flashes in my eyes. I was diagnosed with dry age-related macular degeneration. I was prescribed AREDS2. Is there a benefit in supplementing the AREDS2 with an additional micronutrient of some sort? And the answer is we don't know. We don't have great data on altering the AREDS formula. As long as you're getting the AREDS or AREDS2 formula, the AREDS2 formula is vitamin C, E, zinc, copper. Oh, my microphone expired. It's C, E, zinc, copper, lutein, and zeaxanthin already in the AREDS2. Is there a benefit in supplementing the AREDS2 with more lutein and zeaxanthin?
that's what the drug vitamins and multivitamins generally.
Yep, so the AREDS2 formula does have lutein and zeaxanthin in it. I don't know of any evidence that there's a benefit in taking more lutein and zeaxanthin. There could be, but you know, my recommendation to my patients is to take AREDS or AREDS2, and the AREDS2 has the C, E, zinc, copper, lutein, and zeaxanthin. The regular AREDS has C, E, zinc, copper, and beta-carotene as the carotenoid, and I don't know if there's benefit in supplementing beyond the AREDS and the AREDS2. There's not a lot. There's a lot of supplements out there. You walk down the supplement aisle, there's so many supplements. You look online, everyone's got a supplement. You know, I should have Eichenbaum's Magical Eye Elixir or something like that. I don't have Eichenbaum's Magical Eye Elixir, but everyone wants to sell a supplement, and I don't see much evidence for supplements other than AREDS or AREDS2. Yeah.
Well, what will keep the drusen from forming?
Yeah. Oh, it's the Nobel Prize question. How do you keep the drusen from forming? It's tough. You know, you pick your parents better. You pick parents with good genetics for not getting drusen, and you don't survive very long. So neither of those are good answers. You know, neither of those are good answers. But the drusen formation is probably determined by genetics and time more than anything else. Great question. We have one other question here to follow again.
Yes. I read someplace about immunotherapy being one of the programs that is working on.
Yeah. So it's a great question. Immunotherapy, there is a tremendous push to use interleukin modifying agents, which I think is what you're talking about inside the eye. Immunotherapy that's being looked at for ocular inflammatory disease and diabetic eye disease before macular degeneration, because those diseases are probably more inflammatory than macular degeneration. But molecular therapy, meaning antibodies against these certain inflammatory proteins, is currently an ongoing research initiative, in phase 2 and phase 3, and we will hopefully have our first interleukin modulating injection available for inflammatory eye disease sometime in 2026 or 2027, depending upon how the phase 3 readouts go. But immunomodulation is definitely one of the focuses, but not specifically for macular degeneration.
The article that I read said that it would regenerate cells in the retina and restore sight.
Yep. So this is probably a conflation of different topics. The question is, will immunomodulating therapy restore cells in the retina and regenerate sight? Probably not. The restoration, the regenerative therapy is more like stem cell therapy. That cell therapy is regenerative, and that's what's going into phase 2, which I'm super excited about the potential of cell therapy. And when you do take cell therapy, you often need to go on immunomodulators, like systemic immunomodulators, to keep the cells from rejecting. Either corticosteroids or more potent immunomodulators. But those go hand in hand. The part that's regenerating the vision that isn't the immunomodulation, in that article it's probably referring to cell therapy, which is the stem cells. But then when you get those implanted, in the clinical trial that we're enrolling, that they're implanted, you have to immunosuppress the patients so the stem cells don't reject. And that's a tricky thing. The stem cells are tricky. Why are they tricky? They're tricky for 2 reasons, well, several reasons. The biggest ones are you have to keep them alive, because they're injected alive. They come from these cell lines, and then the body wants to get rid of them because they're foreign cells. So you have to take your elderly patient with macular degeneration and suppress their immune system for an as yet undetermined amount of time to keep the cells alive. There's risk in that, but we're going to try it, and try to keep people healthy and immunosuppress them and keep the cells alive. And the second thing is, okay, you got the cells, you got them in there, you've kept them alive, you've kept your patient alive, everything's cool. Yeah. Then what do the cells do? That's the second tricky part. You want the cells to differentiate into functional retinal cells. You don't want them to grow into cancer, you don't want them to grow into scar, you want them to grow into the right thing. That's the second tricky part. The cells have to grow just the right way. But because of the technology that's built into the cells and the phase 1 results, we believe there's a good chance that most of the cells will do that. But it's early phase. You gotta keep the cells alive, you have to immunosuppress the patient, and then you gotta get the cells to do what they're supposed to do. So it's a lot, but it has tremendous potential. That's how we could restore vision, like you're saying, in macular degeneration. We could restore neurological function in folks like Christopher Reeve, who have spinal cord injury. That type of technology, restored neurological function and dementia. There's incredible technology if we can get the cells to survive and behave. But they're like naughty children, I think. I think it's going to be hard. Yes, another question in the back? Yeah.
I was diagnosed with GA back in 23, and through the research, I did 3 studies for 20-year studies, and I was kicked out for potentially having Stargardt's. And the DNA came back with Usher's and Stargardt's. Is there a relationship between Stargardt's and GA?
It's a great question. So is the relationship between, what is the relationship between Stargardt's disease and GA? So GA is geographic atrophy, the common late stage of dry macular degeneration. Stargardt's disease is an autosomal recessive and inherited retinal dystrophy. Stargardt's disease in its early stages, in folks in their 30s, 40s, looks different than GA. It has these little, what we call pisiform flecks. It looks like fish swimming around in the back of the eye. The late stage of Stargardt's often can look like GA, and it's hard to tell them apart in the clinic. When you send the images into a reading center in a clinical trial, and if you do genetics, if you send the genetics into as part of screening for a clinical trial, that's when you can tell them apart with certain multimodal images, and with the genetics you can tell them apart. Plus, if you had symptoms in your 50s, it probably is, 40s or 50s, it's probably Stargardt's and not geographic atrophy, just because it's a younger person's disease. Stargardt's does have, the relationship clinically is that Stargardt's does have atrophy and thinning of the retina, but the clinical trials for Stargardt's are different than the clinical trials for geographic atrophy because the mechanism of the thinning is different. There's a phase 3 program that read out from a company called Alkeus looking at a special form of vitamin A, which is very promising for earlier stage Stargardt's. But I think in general that certain pipeline therapies like the stem cells, the cell therapy we're talking about, will probably be beneficial for both Stargardt's and GA. But it is in a regular clinic, it's easy to confuse late stage Stargardt's with geographic atrophy.
In the part of the stem cell, is that autosomal or another source?
So the phase 2 stem cells in geographic atrophy now are not autosomal, they're embryonic. They're from embryos that are long gone, and these are cell lines derived from the embryos. They're not autologous stem cells. The autologous stem cells were what was being injected in South Florida in the eye without control from people's own spun down fat or what have you. That didn't work out well. The current stem cells being done in controlled trials injected subretinally are embryonic stem cells. Yep.
Stem cells are great, but they're these early days.
Yeah.
And you cited the problems with stem cell therapy, but are there any drugs other than Preservision, AREDS, that are available to treat dry macular degeneration?
So, great question. Are there oral drugs available to treat dry macular degeneration? We are trying. There was recently an unsuccessful study from a company called Alexion that we enrolled looking at an oral therapy, an oral complement modulator. It's very hard to get therapeutic levels of a drug into the eye without making people sick systemically. That's the problem with oral drugs for treating focal eye disease. Macular disease is an excellent question because we'd love to have an oral. I would love to just have a pill for macular degeneration other than ARED, something stronger. The problem with getting the concentration in the macula leads to systemic toxicities. You end up mostly with liver toxicity or kidney toxicity because of the levels that are required. We're still trying. There's still conceptual drugs. I don't know of anything in phase 2 or phase 3 right now that's enrolling for oral therapies, but we've looked at several drugs, including even something as simple as high-dose doxycycline for anti-inflammatory properties years ago to something complex like Alexion's danicopan, which was the oral drug that just failed to meet its primary endpoint. And even though it didn't work, it did have some patients who had toxicity and had to exit the study. The toxicity is reversible when they stop taking the drug, but getting the concentrations in the eye that are therapeutic are very hard to achieve with oral medications. The other systemic therapies we're looking at are injectable subcutaneous therapies. There are several studies looking at injectable subcutaneous therapies. Those are the subcutaneous injections that are given under the skin are often drugs that are better targeted than oral medications. So I'm hopeful that we'll have an option of a subcutaneous treatment for dry macular degeneration. There's 2 late-stage trials now. There is one that's fully enrolled looking at a daily, everyday subcutaneous injection for intermediate dry macular degeneration. Every day. That's a lot of subcutaneous injections. And the second trial is looking at, that's enrolling now from Regeneron, actually, your partner here, Regeneron, is looking at a subcutaneous trial once a month for dry macular degeneration in combination with the injections in the eye. So there's technology looking at systemic therapy, but orals are going to be hard. The AREDS2s, the AREDS and the AREDS2 studies are kind of unique and interesting and standalone because those vitamins are so benign. They're also not very effective. You know, the risk reduction with AREDS and AREDS2 is small. It's important because it's so safe and it's so inexpensive and it's so accessible, but it is not a very potent intervention. It's a great question. We'd love to have an oral. Yes, in the backpack.
You mentioned not to give up Medicare.
Yeah.
Well, in fact, that Part D has to be, Medicare won't pay for pharmaceuticals or drugs you just mentioned, but Part D is expensive, very expensive.
Yeah.
So are these, I assume these drugs that you just mentioned are expensive. Which one is the most effective?
So it's a great question. The drugs that we're talking about are pipeline therapies. We'll do a two-parter. The question is, the drugs are expensive, which is the most effective? The pipeline therapies are not available for sale, so they are all free through clinical trials. There's zero cost to pipeline therapies, and most patients get stipends when they're in pipeline therapies. When they're commercial, they will be very expensive, and getting access to them and getting coverage is a whole different thing that the drug companies have the responsibility to do. The commercially available drugs, the Eylea, the Vabysmos, the Pavblu's, the Lucentis are also expensive. And which one is the most effective? It's a great question, and all the data we look at see them being equally effective. They're equally effective. Even the Avastin is very effective, probably a little less effective, but still a very good drug. The difference between the expensive drugs is how long they last, durability. There's no expensive drug that's been shown to be more effective than other expensive drugs from a visual acuity standpoint, but there are the second generation drugs, the Vabysmos and the Eylea HDs have been studied with very long durations between the injections, and by long durations I mean 16, 20, 24 weeks in some studies, and about half the patients with the expensive new drugs can get to 16 weeks in the first year of treatment. Some patients can go very long on older drugs, and we had a question to start out the session that I'm going 4 months between shots on the 20-year-old Avastin drug, but that patient had had induction with the Vabysmo, so that may have changed things and set her up for long intervals between the Avastin shots. But the drugs are not better efficaciously. The newer drugs are better durability-wise. That's probably the difference. We're looking for drugs that are better from an efficacy standpoint. But the most important thing for efficacy, I still think the most important thing for efficacy, probably for the rest of my career, is coming in early when you have wet macular degeneration. Coming in with early disease and good vision to start with is probably better than any drug we're going to get. Yeah.
How do you go from the Eylea, and 2 milligrams to the 8 milligrams, you were stating that there was a difference in vision clarity?
Durability. Durability. So how do you go from 2 to 8? Switching patients from 2 to 8 has been looked at in the real world in studies, and it does work. There is no issue as far as safety or efficacy going from 2 to 8. It seems that patients who go to 8 do go longer in the real world. They gain, it seems, between 2 and 4 weeks in most real world studies looking at the switch. How do you go from it? You talk to your retinal specialist about how you'd like to go longer between shots, and you heard that Eylea 8 is more dosage of the drug that's working for you, and this guy at the Macular Degeneration Association told you it goes longer, so can you think about a switch? And they'll talk to you about it. But you know, we switch in the real world. We switch between the drugs routinely, and I don't think there's any problem going from 2 to 8. I've switched many of my 2 milligram patients to 8 who are doing well on the 2 because I like them to go longer between the drugs. Now, not all of them. Who has not been switched? Patients who've not been switched fall into 2 big buckets. Number one, patients who are doing great on the 2 and are 16 weeks or so on the 2. Am I going to switch them to the 8? You could, but why don't I try keeping them on the 2 every 18 weeks maybe, so I don't switch them if they're doing great. And the second group of patients have access problems. Either the 8 milligram doesn't get an authorization from their Medicare Advantage plan, or there's a higher out-of-pocket cost for the 8 milligram. But otherwise, many of my 2 milligram patients have been switched to 8 because I do like the idea of them going longer. Everyone likes the idea of getting fewer shots.
So the 2 milligram Eylea should go for at least 8 weeks per
So does the 2 milligram Eylea go 8 weeks between each shot? In most patients, yes. But I would say there are probably about 10 to 15% of patients on 2 milligram Eylea who are dry, if they get, but who are dry at an interval more frequent than every 8 weeks. Yes, so great question. Can we replace the shots because the shots are the worst? Yes, the shots are not ideal, and the technology to replace the shot that's commercially available is the port delivery system implant. You can look at the implant, especially if you're getting shots frequently, and And then there's pipeline technology. There are clinical trials for treatment-experienced patients looking at the gene therapies, which make the eye into its own biofactory. The eye produces its own drug. Those are the two technologies that are looking to replace the shots. There are better shots coming too. There's a whole different class of shots called tyrosine kinase inhibitors that are fully enrolled in phase 3 that work differently than the Eylea and Vabysmos and Lucentis, and those will probably be an additional therapy in combination with the existing shots if they make their primary endpoints. If they're approved, that would reduce the frequency of shots. It's like cancer therapy. Very few cancers are treated with one drug. Most cancer therapies are a combination. There's a cocktail that people refer to. This is my cancer cocktail. I think that for macular degeneration, for wet macular degeneration, we're going to have a combination. It's going to be like a cancer cocktail. You will have, of course it's not cancer, it's macular degeneration, but you'll have the legacy therapy, which are like the Eyleas, or the Vabysmos, and then you'll have additional therapies. You'll have the tyrosine kinase inhibitors, which we didn't touch on, but it's a different type of injection that works a different way in combination with the existing drugs. And potentially there'll be some very severe patients who need a gene therapy and a tyrosine kinase inhibitor and occasional Eylea shots. Because if you're a cancer patient, you're usually taking 2 or 3 or 4 drugs to quell the cancer. And I think that general philosophy will translate to other proliferative diseases, like diseases that have leakage and cell growth that shouldn't be there, like wet macular degeneration. So I think that there's things coming. Most of them are shots, but to get away from the shots in 2025 today, in the reality of today, you got the shots and you have the port delivery system, the implant. If you can't tolerate the shots, you're getting the shots frequently, I think the port delivery implant is a great technology to talk about with your doctor. It's called, the name of it, if you're wondering what it's called, it's got a fun brand name too. It's called a Susvimo, S-U-S-V-I-M-O, but I think I referred to it as a port delivery system. Yes, in the back. Wait, in the back, you didn't ask a question yet, yes.
I had diagnosis of the dry macular, but I have a long history of ocular hypertension. And when I have not started the injections yet, but if I do, what do you feel that, what does that do to the...
So it's a great question. It's an excellent practical question. Question is, I have ocular hypertension and I'm maybe going to have to start injection someday. Number one question, is the ocular hypertension controlled on drops?
No, not needed.
Not needed,
You're
yeah.
monitoring the optic nerve all along.
Yeah.
So say it's around 22.
So that kind of patient, your kind of patient is well studied. In the clinical trials, there were patients with ocular hypertension without treatment and glaucoma with up to 2 different agents in the study, and there was not an increased incidence of glaucoma when patients got shots. So if you have controlled ocular hypertension or ocular hypertension that doesn't require treatment, it's probably safe to take the shots. Now, after dozens of shots, do some patients' pressures go up? Yes, but we don't know if that's related to the shots or just the passage of time. So at some point, you may need to get the ocular hypertension treated whether or not you're on the shots. But if you do need the shots, let's say you convert to wet macular degeneration and you need the shots to preserve the vision, the benefits of the shots exceed any risk of worsening the ocular hypertension, because there doesn't seem to be an association between the shots and the worsening ocular hypertension.
Thank you for answer her question, and then I've got to take it.
Okay, all right. I'm glad we had robust Q&A. I see one more hand up in the back there, so let's answer that question in the back.
Concerning the treatment of dry, how long are you in your process of criteria to accept giving Eylea as a treatment, especially since it's been approved in Europe also? And second part, is there any other treatment besides Eylea for dry?
So it's a great question. The question is, how far along is our practice in considering offering a Valeda. We'll probably make a decision on the Valeda by the end of the year, and decide whether or not to get one Valeda and offer it. And it's a tough one. Even if I had the Valeda, what I would say to a patient is, you have intermediate macular degeneration. There's data from a small group of patients supporting vision gain. If you do this photobiomodulation, it's going to be expensive, it's going to be frequent, and it never stops. Every time in the evolving data set, if you stop, it seems that the patients get worse. So it's expensive, it takes a long time, and it never stops, and it's a small data set. But there's a positive trend towards it, and it might very well be helpful. And that would be the offering for the Valeda. And I would love to see more data. There will be more data on the Valeda. I think it's going to be real world data. I don't think there's going to be any more controlled trials on the Valeda because it's approved. But real world data on the Valeda is the next thing we're going to have to collect over the next several years. Other things for intermediate that are interventional or investigational, we have the next card to flip will be the results of the daily subcutaneous injection for intermediate AMD, which is also not ideal because even if it's accessible, it's an injection every day. But the best thing for intermediate AMD is still to take the AREDS vitamins. And if you have, I don't know if anyone has a Valeda around here yet, but if someone does, and that's an offering that's appealing, that's something to consider for intermediate AMD. It does not help geographic atrophy, it does not help wet AMD, it's specifically for intermediate dry AMD. That's a great question, and like I said, I think I started out the talk that dry AMD is the biggest unmet need in retina. We really need to do better. We're trying to do better for dry AMD. All right, I'll turn it over to Donna. Oh, wait, one more, yes. I think there was one in the back who hadn't asked one yet, too. Yeah. Well, that's two more questions, I'll be done. Quick answers, I'll keep it to 60 seconds. Yes?
I'd like to know if ocular migraine and retinal edema can be a precursor to the macular degeneration.
Excellent question. Ocular migraine, no. Retinal edema definitely is a problem. Might be wet macular degeneration. You got to find out what the reason is for that edema. That can be from macular degeneration, can be from diabetes, can be from inflammation. Ask your retina specialist, why do I have retinal edema? And that'll answer that. Great question. Don't worry about the ocular migraine. Yes?
Are there any clinical studies on medical marijuana to help macular degeneration, or I know in glaucoma,
so great
drugs are better than marijuana?
Great question. I am not a prohibitionist. Number one, I have no problem with marijuana use, recreational or medical. Everyone, you do you, totally cool. As far as the actual therapy of THC for retinal disease, we did have a study looking at a non-cannabinoid THC in diabetic retinopathy, looking at a THC derivative that was given systemically to see if it would reduce diabetic retinopathy with anti-inflammatory properties. And a really funny story about enrolling that, I had like 2/3 of my patients screen fail because they all failed the urine drug test for marijuana. Everyone's using marijuana, so they can't be in a study testing the use of THC if they're already hitting the pipe every day. And these are all older patients. It's really funny. So I just began to ask them, but everyone was screen failing because everyone's evidently a pothead, which is fine. I love potheads. It's totally fine. But I was asking her, I said, listen, I have to urine drug screen you. So if you're going to fail, let's just skip it. And people would be honest. They'd be like, doc, don't bother, I'm going to fail. But that study, we did enroll that study. We looked at it in diabetic retinopathy, the anti-inflammatory properties of THC as a high oral dose. Didn't work, didn't help. So THC is probably not good for any known ocular disease, but it probably is good for anxiety, depression, and to make you just have a nice, pleasant evening. All right, on that note, I'll turn it over to Donna.
Congratulations, those presentations were fantastic. My chairman of the board had a family emergency, so he had to leave. So now I'm in charge, and thank you. Don't forget your thumb drive. It's right there. So things are going to be just a little different because I'm not a video person, so I'll try to do my And I'd like to have the Division of Blind Services and the Lighthouse. Now let's come up front here and let them talk to you about some of the things that they can offer. They have classes, they have a lot of great opportunities for you. And I'd like you to hear from them, and then we'll go on to Samsara for a quick presentation, and then we'll take a quick break and come back, and hopefully I'll have your video for the next one here. Hi, Amanda. Here you go. Thank you.
Hi, good morning, everyone. My name is Amanda. I'm with the Florida Division of Blind Services. I'm the Independent Living Counselor for the program. Division of Blind Services, we are a state agency that refers people to different programs and organizations like the Lighthouse of Pinellas to provide independent living skills training to people who are visually impaired. I did want to touch briefly on one of our more popular programs, the Senior Equipment and Training Project. Some of y'all may be familiar, it is an initiative primarily funded by, sponsored by the Blind Services Foundation to help seniors and people over the age of 55 get their hands on assistive technology devices such as CCTVs and smart readers. Due to the popularity of this program, we have been told, I was told yesterday, that it has been authorized for another year. We are still waiting for a little bit of guidance on how to proceed with our folks that have been waiting for a device and folks that are interested in applying for a device in the future. I do expect it to come up when I go to a training next week. I'll be at the office for a training and do expect to learn more guidance. And as soon as I have that guidance, if you have talked to me before or in the other program, if you've talked to me before about getting a device, I'll be contacting you with the new guidance. And if you'd like to learn more about the Senior Equipment and Training Project and any other services that Division of Blind Services have to offer, you can absolutely go on our website, that's dbs.flboe.org, learn about our services, apply for the program, and find out how to get in touch with us. I'm at the table in the back, right next to the lighthouse, and I'm going to pass it on to my friend now. Thank you very much.
Good morning. My name is Sherry Gavin. I am the Development Director for the Lighthouse of Pinellas, and we cover all of Pinellas. We have classes from early education, so we have babies, all the way up through seniors. So we do children, teens, adults, seniors, we do all ages, and babies as well. So, our mission is to help people with low vision or people that are blind. So we want to give them more independence and have them build their confidence. So for the adults, we have many different programs that we offer. I am also in the back, and you can come pick up one of these. We have teaching of the white cane, which is orientation and mobility. We have activities of daily living and pretty much adjustment to vision loss. It's a combination of a Wellness Wednesday where we have therapy in the morning or the afternoon. You can do it by Zoom or come into the office. And the activities of daily living are just so you can adapt to your daily life while you are going blind or if you are blind. So we can help you adapt in the kitchen, in the home. We have kitchens in our facilities. Somebody's always cooking something. Always smells so good in there. Many of the classes cook desserts and cook lunches. We also have assisted technology, so you can use your iPad, your tablet, or even your phone for many different things. And the vocational rehab is for those that want to go back to work or continue working. We help with that as well. So we are here in Largo. We are not that far away from here. So we'd love to have you come in for a tour if you'd like to see it. Your doctor can refer you to us, and we will take care of it from there. And we work with Division of Blind Services. We also have a walk coming up. It's a fundraising event, November 8th, which is a Saturday, and it's at Largo Central Park. And our programs are absolutely free to everybody. It doesn't matter what type of money you have, if you're on any type of insurance, we don't take any of that. Doesn't matter what you have in the bank. Our programs are free. So our walk is going to be to help raise money so we can continue to do that. So thank you all.
Dr. Mason to the front to talk about Samstar Vision. It's a miniature telescope, and he'll give you more information. And Don, I'm so sorry, but I thought that you're really
It's quite all right, Dr. Thank you. So good morning, everyone. I'm Don Rancer from Samstar Vision. And I want to thank you all for coming out. I also want to thank Don and Larry and everybody for the opportunity to support this important educational event. So what do we do at Samstar? We have an investigational device that's an implantable miniature telescope. It's geared towards patients that have been diagnosed with late stage AMD, and those are the friends and family members who could read and no longer read. They can no longer watch television, or if for some reason, unfortunately, they appear at this event, they would be able to see the screen. There's no cure for AMD, but what the device does is it helps take what vision you have and get you to the point where you can see more than just the big E. It's called SING-INT. That stands for smaller incision, because our original device that we started with about 15 years ago was much larger. It was a little bit more of a major surgical procedure. This device is implanted during a normal cataract procedure. If you think about the smallest flower that you would think of, it easily sits on the tip of your finger, very, very small. And I have documentation materials in the back if you want to learn. Excuse me. If you want to learn more about it. So if you have friends or family members that are in this situation, please stop back. We have information on what's called a concerto study, where you would get the device if you qualify at no charge, and although not approved here in the United States, it is approved in Europe. We have over 500 cases, and we're trying to get it approved here in the States so that we can help patients see better and hopefully change their lives for the better. Thank you.
Do you guys want to take a quick, well, no, I want you to take a quick break. Go to the back, because they have a lot of great information back there to share with you. And figure about 5-8 minutes, then come back, and we'll proceed with the next program. Thank you.
Talking, but very disturbing.
All right.
like, is it good? Is it,
It hurts my stomach.
makes sense, right?
My neighbors who say it's international. He lives in Costa Rica. Had a coffee plantation. And he asked, well, what can I do, after the election? What do you do with your ground beans? You sell it, he said. You sell them to a very popular American distributor.
No. Learn something every day.
My marketing girl was like, I shaved off years of my life trying to make that video. I'm like, good job. I can finally get big. It was a lot. I was thinking it was going to be a little easy, but
Odd place to put it on the side. Thank you.
Right.
Oh, that's water. That's That's decaf. This is regular, and that's hot water. Try them all.
Yep.
I was about to say, I'm like, I was looking for the ink. They got the person to start I could probably, I got it. I just need to know, like, I can eat
Thank you.
Just a quick introduction. I am a native of Fort Myers, Florida. I'm a graduate of Nova Southeastern in Fort Lauderdale, and after my time there, I went and studied and worked at the University of Florida. And it was at my time with the Gators that I actually started working. I took over the low vision department of that organization. And for 8 years, I worked for them, leading that department and teaching the residents. And that is when I met Bob, one of the owners of the companies back there, the magnification company. We've known each other over 10 years. And then my education history ended, and I moved back to my hometown because I had a baby, and that's where all my family was. So to help me raise my daughter, I moved back to Fort Myers and opened my own practice a few years after returning. At my practice, I see general patients, but I also specialize in low vision care. That was something I did at the University of Florida, and so I continue to do that in my own community. So my job today is to try to not so much convince you, but to help you understand why you should see an optometrist that specializes in low vision. I answer the phone at my own office, and every time, sometimes I make the calls to patients when I get a referral from a retina specialist. That's my primary referral source. And I'm the one who talks to the patients on the phone, because mostly I receive questions of, why am I coming to see you? What can you do for me? So this is what this topic, this lecture is about, okay? So we're going to first understand the definition of visual impairment. We're going to understand, hopefully at the end of this course, what a low vision exam is like with an optometrist, and of course, understanding my role in this. So the definition by the American Foundation for the Blind of visual impairment is loss of vision that may be severe enough to hinder an individual's ability to complete daily activities, things we take for granted, such as reading, walking outside, cooking. But these individuals retain some usable vision, okay? They cannot be corrected any longer with glasses or surgical intervention or medication. That's the one line I don't quite agree with, or I would be out of a job, right? There's still lots of hope for many people, okay? Just finding a different way to live, okay? Struggle, but these individuals do struggle with a lot of things that sometimes glasses and visual aids can't help, like light-dark adaptation, contrast sensitivity, navigating in the dark. So when patients come to me, a lot of times they are saying, I can't see distance vision well, I can't identify someone walking up to me. This whole slide's about kind of complaints I hear about. They may be familiar with their home and the layout of their home, but in unfamiliar environments, they are at fall risk. Computer usage can be a little difficult if they have near vision complaints, meaning they can no longer see normal size font. Patients tell me when they're playing cards, they can't see the cards anymore. They can't identify somebody's features on their face to tell if they're smiling or frowning. You know, they can't tell those features. And that's all from usually age-related macular degeneration that takes away your central definition vision. Of course, there's other activities of daily living, like meal preparation, eating off a plate, watching TV. We try to listen to the goals the patient has and work on those goals to try to achieve them. This is a very short summary of what we do during the exam. My exam can be an hour and a half to 2 hours long that I take with a patient. That means, you know, the longest part is sometimes history, acquiring that history. I'm asking a lot of questions, you know, do you live alone? Do you feel comfortable where you live? What are your needs? Tell me some goals that you'd like to achieve that are, you know, within reasonable ranges, okay? And sometimes that takes time. Why am I asking all these questions? Because I work with other services, like the Division of Blind Services, Lighthouse for the Blind in my area. If I feel that you need to have a letter written to reach out to these organizations, I do that for you. Some patients do ask me to write letters related to their apartment status, government. I fill out all those forms, okay? So I have to ask you a lot of questions, but it also helps me understand where my goals are for you, okay? So we don't do, I rarely fit somebody behind a fluoropter, which is a fancy word for this 1 or 2 machine, right? Which is better, 1 or 2. Everybody's used to this. Most low vision patients or patients that have any visual impairment, they don't see through this device very well, so we do everything in a natural environment in a trial frame with loose lenses. So that takes time, but it's something that's more natural and patients feel a lot more comfortable with us doing. But we also use very specific vision charts that you may not see at your local retina specialist. A general optometrist is generally just using a chart that's mounted on the wall called Snellen. It's a standard, good vision chart, but not really adequate for individuals that have any kind of visual impairment because it is unfair. You need to have equally spaced letters that are equally difficult. And that is kind of given to you in different charts, like Fine Bloom or ETDRS, something that's movable. And those charts I have in my office for a certain reason, because it gives you a fair chance to see. The purpose, though, of the low vision exam is really, you see it's highlighted there, hopefully to correct vision, the visual acuity better. I have more than 50% of my patients that come to see me that are not wearing glasses at all. And I find that wearing a prescription, just because nobody else tried for the last few years does not mean you can't see better with a prescription. So we do that as our first line step. I tell my staff, I don't care if their vision's 2200, count fingers, we're still gonna refract that eye and see if it can see better. If that means getting the peripheral vision clear, that's a win, okay? So plus, you need to be wearing glasses anyways, as a form of protection, especially if you only have one good eye, okay? I've had a few of my patients lose their only good eye from accidents that they did not see coming. And so we start with glasses. 50% of my patients, we get vision better. So we start there. If that fails, or they need more help in seeing or reaching the goals that they need, then we use visual aids of various sorts, sometimes handheld, sometimes stands. I love digital devices. Oh, I'll skip this. But I also do refer my patients to a low vision occupational therapist that's in home if they need some care in home, a skilled nursing facility, psychiatric support. That's my job. I'm your bridge to get you to whatever you need to do. And usually I have those connections in the community to do that for you. These are some of the visual aid devices that I'm very used to handling, but they don't work for everyone. I love digital devices. They blow the handheld magnifiers out of the water when you get to a certain level of vision. Digital devices, especially the VR devices, the wearables, are so amazing. If you have not tried one of the wearables or meta glasses, I always advise, please try them. It's not hurting you or harming you to try something new. It may feel very overwhelming to try something new and a little scary, but you can't beat some of the digital devices, I don't know if it's closer, and what they can kind of magnify for you and clarify. It's just very impressive. So I still believe the #1 tool out there is going to be your phone. You can do anything with that phone. Text to speech, there's apps that read to you. If you can figure out or have someone help you with just a standard iPhone, tablet, that is still the #1 device that can do the most for you. I still have patients that read the Kindle. You can maximize your font on the Kindle. It can read to you in some of the newer models. Very helpful for those avid readers. So I'm all about these little digital devices that we kind of use every day. Like I said, it's really hard for me to summarize what I do in a 10-minute, slide lecture, but if you have questions, please feel free to ask me. I hope that you ask questions. I have so many people that call into my office just to ask questions, and I'm happy to answer them, because it's the unknown is a little scary. But if you ask the right person the right question, hopefully they can help you in answering that. If you need to email me, feel free. That's my email related to my private practice. And thank you so much. Thank you for bringing over your time. Yes. Oh, yes. No.
Okay, so at this time, we were going to have a video on eSight, but because, unfortunately, I'm not versed in his computer nor how to find it, Bob so graciously offered to speak about it along with his products as well. So he'll give you the down low on all of it. Bob?
about medical glasses, you have to know. I depend on him to train my patients. I don't have the time to train them.
Can everybody hear me? Everybody hear me okay? Oh, well, no, I don't think I was on
Now you can. So I am your eSite video in live format. As Donna said, first of all, happy Saturday. Thanks for coming, all 30 to 40 of you. And I really appreciate the arrival time here. I know this goes on for just a little more time, and it's college Saturday football, so I won't be too long. But like Dr. Cameron, it's very difficult to go over all the components of what we do. So I'm going to try to wrap this up and make it really exciting and let you know what's going on here with what I do in this world of low vision and the devices that we provide. I'd like to thank Donna and Larry, who left earlier, for inviting me as well. This is about the 4th or 5th time I've been invited to the Macular Degeneration Association presentations across the state of Florida. So I must be doing something right, Donna. I can't figure it out. Gainesville, October 13th. Follow the comedy tour. Here I am. Anyway, so my name's Bob Schrepfer. I own a company here that is headquartered out of St. Petersburg, Florida, called the Magnification Company. Has anybody ever heard of that company before? Raise your hands, other than the vendors in the back. Nobody. That's extremely sad. And I'll tell you why. Yes, sir, you did. 1? Perfect. 1 out of 30. It's sad because over my career, this month being 39 years in low vision product technology of helping those that are anywhere from moderately visually impaired to totally blind with technology that comes to market, that the awareness and the communication is still at a very, very pathetic format of letting you and the audience here today know what's available to keep you visually independent. And when it comes to any of the eye conditions that have been discussed today, macular degeneration, diabetic retinopathy, glaucoma, it goes on and on. What it comes down to is when you get to the position in your unfortunate visual journey of vision loss, being moderately visually impaired, hopefully not, but see many, many folks that are totally blind, whether it's from an early age or at birth or along their journey. They have no idea that their life of visual independence can continue to keep on. And when we partner with doctors like Dr. Cameron and Dr. Eichenbaum, the Division of Blind Services, the Lighthouse of Pinellas, the VA hospitals with their blind rehab programs, and it goes on, getting the referrals as we do makes a life-changing difference for people. There was a lady that I spoke to that left, unfortunately, and she didn't have macular degeneration. Her mother does in New York, but she was talking to me about what happens if it happens to me because I play music, and we had a nice discussion back there on some of the wearable devices that are available, and that's today. And she's nowhere near visually impaired, but the technology seems to come and go quite a bit here in the last 6 months, and it's all for the betterment of helping people that are in that predicament of being visually impaired to legally blind, totally blind. So with that being said, first and foremost, this is what we do. We're located on Central Avenue in St. Petersburg. And if you go back to my little table in the back, that's only got about 8 or 9 devices out of over 400 that we carry for people, which you have no idea what is available. But we have what is known as a low vision technology showroom there with all of this on display. So when somebody comes in, we prefer appointments because it takes us as well about anywhere from 45 minutes to an hour and a half to do a proper assessment. This is not an eye exam. We've already usually had the eye exam and all the workup from your low vision optometrist, possibly your ophthalmologist. If I get somebody referred to me that is out of a group like this today, that says, I want to come by, well, that's fine, but one of the first things I always ask is, who's your eye doctor and when was the last time you saw them? Because it's really important that you continue that care with your vision to see where you are in that journey. So when you come to us, even though we don't charge for an assessment ever, you're not getting a product that is not going to be a waste of your money or your time, quite honestly. Because we present ourselves as more as educators and trainers. You're the one that determines yourself what product's going to work best for you, depending on the task and what you want to achieve. So we have that part of our business model. Part number 2, we travel the whole state of Florida with a team of low vision product representatives that do the assessments right in your home free of charge. Nobody does that. So we bring the showroom on the road, so to speak. Between the phone interview with your vision, what your eye condition is, what your challenges are, what you may be using now that is or isn't working, along with the input from your eye care professional or the DBS. We bring the appropriate 5, 10, 20, 30 devices with us, and we come out and see you at your home. So we can do the assessments on the things that are important to you. Looking at the dials on your microwave or your oven, reading a small microprint off of merchandise in your cabinets, refrigerator. With the wearables, watching TV, looking at your computer, looking at your surroundings in your environment. And if you're in a retirement community, you want to be able to, for the most part, maybe recognize faces again with some of these. And all these products are dictated by you and how much vision you have remaining, more so than what your eye condition is. So that's really what that comes down to. So once we do that assessment, as we call it, then it's up to you. There may be one handheld magnifier, electronic magnifier, a wearable type of device, or several that may be of value to you, but you're the one that makes the decision on that. At this point in time, over 39 years point in time, Medicare, Medicaid, or insurance does not pay for any product, similar to hearing aids. So it's out of pocket, unless you're in one of 2 categories. Number 1, if you're a veteran, you need to go, and we help facilitate this to your local VA outpatient clinic to see if you qualify, and more likely you will, for coverage of these devices, any of them, because they start anywhere from $100 and go to $5,000, by the way. All depends, and remember we have about 400 different varieties of magnifying devices and other types of products. So that's number 1. Number 2, we have the Division of Blind Services. They've got the senior equipment program, as Amanda just mentioned. That number was really in their portfolio of coverage up until 3 years ago. It just got approved again. We'll find out after next week what the parameters and qualifications are. But prior to that, and still going on today and every day, their mission has been to help people maintain their education and their employment. So if you're still working from home and you're a realtor or an accountant and you're 70, 80, or 100 years old, you may qualify to get this equipment if you're visually impaired or legally blind. Because that's where they buy this equipment, to keep you either employed or in school. One of the 2, okay? So, let's see here. Pinellas County, my home base, born and raised here, and I learned about a year ago from the Pinellas County chapter of the Florida Council for Blind that there's between 25 and 30,000 residents in this county alone that are anywhere from visually impaired to legally blind to totally blind. And we have 40 people here. So we could fill a stadium if I myself had the marketing dollars to advertise this and blow it out of the water, because that has been my passion all my life, is trying to inform people what's available for them. So we're not just your typical magnifier store, even though the name says a magnification company. We have so many devices. So magnifiers come with a conventional lens, quite honestly, handheld, or a wearable. Then there's the platform called electronic video magnifiers. Those come in 3 different scenarios. Wearable, so your hands-free, like glasses, tabletop or desktop, or portable handheld video magnifiers that mimic basic magnifiers, but they give you unlimited magnification. Okay. Now, let me see if I have this product activated, because because I got to tell you about this. Getting back to electronic magnifiers, and one of the products that I'm going to represent is the eSight. We carry that product. And we all have brochures on it. That's a wearable unit that you wear, so you can be hands-free with an electronic magnifier to give you a range of magnification from 1 to 25 times. It works wonderfully. And in addition to that, it allows you the ability to see near, far, change your contrast mode if need be, and see the things in a real-time environment without having to be dictated to coming to a tabletop or holding something in your hand. Those are in the upper price range, as I mentioned below. However, they're very effective and have an extreme value for people, providing you have enough vision.
Bluetooth audio device audio 106 Pro connected.
Did you hear that? Isn't that cool? So I got, that's a Bluetooth speaker I have, and it's important that I have that on right now because the eSight, getting back to that, I did not bring one here today because I thought the company would be here with one, so I don't have one here to demo in the back. But please come by, stop by. Our offices, before I get into my next segment here real quick, are Monday through Friday from 9 to 3 p.m., okay? Or you can call us and we'll bring it out to you. Since that's what we do, about 85% of the people we see throughout the state of Florida, we come to them. So let me see if this is activated real quick. Hold on. It is. So what I'm going to do here, you all have this in your little takeout kit. I'm trying to fold this over so I can, okay. All right, so the brochure you got today, it talks about all the presenters and things like that. On the first page it says about us, okay? I'm holding in my hand right now this product called the OrCam Read. It's about the size of your finger. I'm going to point it at this and take a picture of it.
ECE's registered sign video about U.S. The Macular Degeneration Association, MDA, is a non-profit organization dedicated to providing patients with education and advocacy.
Is that fine?
One of the principal missions of the MDA.
I'm going to pause. So when people get to the point where their vision is not going to be helped by magnifying devices, or they get eye fatigue because their magnifier has to be turned up so high, there's what is known as products called OCR, optical character recognition. In this particular case, this converts text to speech. And it will convert text to speech off of any platform. You hear that beep right now because I paused it. If I double beep again,
that distinguishes us from other
it picks up where I left off.
Focus on patient education.
I press it one time, it stops and deletes it. The value of this little guy here, that on a full charge gives you about 4 hours plus of continuous use, and you just plug it in the wall or USB and charge it again. I can be in Publix, and I can be walking down the aisle, and I can be looking up at the ceiling where the menu's hanging and pointing that direction and reads everything off the menu so I know what I'll do. So, it's, whether it's a book, a box, a document. I have several people with this in the retirement community. They'll be walking down the hallway. They don't know which door they're at or what name's on the door for another resident they want to see. They just point it, knowing that that's where the name tag is, and it reads the name tag. It will read information off of any bulletin and off of any monitor. You can point this at your computer, your cell phone, or a TV, as long as the print is stable and not moving, and it will quickly convert it to speech. You have a choice. I'll get to your question in 1 second, ma'am. It will read in either male or female voices. You can increase or decrease the reading speed, so you can slow it down or make it faster depending on your liking. It will Bluetooth, as you just saw, into a speaker for a louder voice, and in some earbuds it will, but it also has a little micro speaker in the product itself. So if you're at a grocery store or a restaurant or a church or whatever, you would just put it up to your ear, and you can hear it pretty darn good. There's a lanyard that comes with it, and there's also what is known as a docking stand. So when you get home, it can go in like a little podium, like a mic, and it points straight down on your tabletop. You can voice command to tell it to take a picture of what's on the table, a book, a Bible, a magazine, and it will convert that right away to speech. This little gem used to be $2,000. It's now $895.
How much?
I knew that was going to be a question. That's why I had to wait. Yes, ma'am.
How much is that?
$895. Okay. It is worth its price in gold. Okay, so now this is my intro because I'm almost up to my time. I give presentations of equipment product and all. You know they're normally an hour long, so I'm really rushing this in. How many of you with a raise of hands have heard of the Meta Smart Glasses? At all. M-E-T-A, Meta Smart Glasses. One person, maybe two. I'm holding a pair in my hand. Some of you can even see it. They look like normal glasses. There's two different manufacturers. Ray-Ban, we've all heard of Ray-Ban probably. The Wayfair sunglasses, you know, the cool beachy ones. And now Oakley, but Ray-Ban has 3 different styles. In these glasses, it puts this OrCam capabilities to shame. Although this is still very valuable, and I'll tell you why in a minute. You've got a camera eye in the left corner of the front of your glasses here. In the back, over your ears, you have 2 speakers. So the sound goes only to you and your ears, hearing aid, whatever. You have 5 microphones that are built in throughout the glasses, okay? So when I put these on, you've got about 8 hours of usability. Not only can I look at something that I'm holding in my hand, or on the wall, or on the sign, and say, hey Meta, read what's in front of me. And it reads it from start to finish, verbatim, only to me, without holding anything in my hand. But it can also read what you want it to read. Where with the OrCam, when you take a picture of something, it will start and finish the whole thing whether you want it to or not, or read things that you may not be that privy to even wanting it to read. So what I mean about that is, let's say you have a utility bill. Say, hey Meta, read what's in my hand. So you've got a utility bill from the city of St. Petersburg. And instead of reading the whole document, you say, pause. I just want to know how much it is and when I have to pay it, and it will tell me. In addition to converting print to speech, it can read handwriting, it can recognize objects in the room, it can do color recognition, so if you're visually impaired, legally blind, you can know colors, or even totally blind, what you're pulling out. It will read currency. It will convert up to 15 languages to English and vice versa. You've got this AI human being that is not anywhere near you, but when I first got these over a year ago, I'm looking down at the floor with my 2 dogs on the floor, and I say, hey Matt, what's in front of me? And it says, there's 2 dogs laying on the floor. Then I said, well, what color are they? And it says, they're white, black, and brown. And because I'm sighted, I can verify all that, of course. And then I said, what breed is it? And it says it's a Beagle mix, and they are. I mean, it's breathtaking on what these glasses can do. In addition to that, it can be calibrated to your contact list in your phone. So when somebody gets the glasses, the primary thing you have to already have in your life is either an Apple or an Android phone. Typically a Series 11 or newer, because that's what takes the free Meta application. That Meta AI app is what's being Bluetooth to your glasses to open up your world of information, okay? And so you can set reminders. You can say, if you're at a hotel, I'm on floor number 3, room number 304, and it will remember that when you ask it later on if you forgot. Has anybody ever heard of this non-profit organization called Be My Eyes? Yes. Be My Eyes is a free application. They're a worldwide organization of sighted volunteers. You can download this Be My Eyes app on your cell phone now without these glasses. The point I'm trying to make here is that that organization, when you tap on that app, dials up one of their volunteers. So if you're legally blind to totally blind, they'll come on, you hold your phone camera eye out in front of you, and they will describe everything in front of you. Free. What's in front of you? A wall, a window, desk, tables, objects, people. What are they wearing? What do they look like? It goes on and on. When you're at an airport, they can read the departure arrivals. They're there to be your eyes. Well, that's still available. But it just made it more effective with the Meta glasses on, because now you don't have to be obvious in front of the public crowd of holding your camera out there. And not only that, the dialogue between you and the Be My Eyes person being heard out in public, because when they're talking through your phone on speaker or whatever, if you don't have Bluetooth, everybody's hearing your conversation. Well, now they're looking through the camera eye of your Meta glasses. Nobody knows nothing but you and that helper. And the sound's only going to your ears, and you can talk as slow as or as low as you want. So it will conform to that. It will conform to your contact list and your phone. So you could have your phone in your pocket purse, in your glove compartment, 30 feet away from you in the house. If the phone rings, you double tap on the glasses and it will answer the phone for you. You talk to the person through your glasses. You can also answer messages through your phone. You can give messages, you can give phone calls. It can also, you can play music. You can play any kind of talking book library you have in your applications on your phone. You can listen to talking books right through your glasses. Laying in bed, your recliner, in the car, not bothering anybody else as well. So the rule of independence that this product, where it initially was kicked off as a product to those that are sighted, still is and always will be, because of this company called Exotica that manufactures this and partnered with Meta. They sell these worldwide to the sighted population. That's who it's mainly been marketed to. We turned this into kind of a low vision product over a year ago. We wrote a manual on it, a brochure. I was written up in Envision magazine, like the #1 optometric magazine. And now with our training program that we have for the visually impaired, because they had a very difficult time loading down the app and doing all this, we can do it with you. Because you can go to Best Buy or Sunglass Hut or any of these other places and buy these, and they'll say, here's your box and it's this much money, thank you, have a great day. Not only that, when you get the glasses from any other type of source, whether it's online or not, you'll get the glasses in the carrying case, which carrying case I have in the back, which charges the glasses. But what you don't get is the USB charging cable, the charging block, the lanyard, nose pads, and the bump dot. So we made it like an ADD accessible kit that we include with the Meta glasses. We also have, if you buy glasses that are very clear, we have the new clip-ons that are custom made for the wayfarers. A clip-on with that. If anybody's ever used a no IR sunglass filter or a Cocoons sunglass filter, now you can have a filter of an amber yellow, a boysenberry blue, a black, a light brown, to cut the light and reflection glare. Those are $25 additional, by the way, those clip-ons, but they make all the difference in the world. Last but not least, you heard the Orcam was $895, depending on what model, Oakley or Ray-Ban, and whether you get it with a clear lens, a polarized lens, or a transition lens. The cost of these are between, are you ready? $300 and $500.
No way.
No way. It is way. Yes.
The read stationary only. What if you're driving and want to read the
Signs. So I tried that. So the question was, is a read stationary only? What if you drive? So I did that because I'm sighted. You don't drive with these on if you're legally blind. If you're not going to correct your vision, they're giving you a verbal output on everything. So it depends how fast you're going, number one, in the car, how far away you are from that printed information, number two, and how big that print is versus the size of the print, letters on the sign at that distance, and number four, the lighting of the environment. Is it at night, during the day, or what it can be? Because I've had to work on multiple road signs and all, on a slow speed, at a certain size on the road sign, or whatever. I mean, one of the other things I did with this in my car as I'm driving, and I wear them all day long because I have the sunglass ones, I'll say, hey, Meta, what's in front of me? I'm at an intersection. It says you're at an intersection with a traffic light above you, with cars to the left and right in front of you. So then I said, well, what color is the car in front of me? It says it's a greenish color, a dark green. And it was. I go, what type? It says it appears to be either an SUV or a van. Then I said, what's the license plate number? And I'm 40 feet behind it, read it verbatim. So these types of things.
You read it or you saw it?
It read it. It read it to me and I saw it because I have my vision, but it read it to me, which was the point of the exercise for that. So, yes, you have that. I had perfect vision.
Okay.
Yeah.
You're cheating with them.
Well, I'm not really cheating with them. I'm using them to give a test daily, constantly on new things so I can relate that.
Maybe I can test them.
One last story I got to tell you all. This is going to, it's going to be, yes, go ahead.
I have poor vision, like if you're 10 feet away from me, I can't make out your face.
That's not going to make out my face or my expressions for you.
Okay.
It's only giving you a verbal outcome of what's in front of you, your surroundings, objects, color, verbally, right, print, text, things like that. Right. Well, that would be something for like Dr. Cameron to give you an eye exam on seeing a prescription in there, because these are frames that you can put your prescription into, if that would help somewhat, but more than likely, just again, depends on the level of vision loss that you have. One last story, I can't wait to share this after the fact. Next week, I'm meeting with this gentleman, his name's William Peace, up in St. Augustine. He's legally blind, and he runs an organization called Blind Golfers of Florida. Yes. You would not believe how good these men and women are that are legally blind to totally blind. Of course, you have to have some assistance with a sighted person in some cases. Anyway, the Oakley glasses on their latest advertisement is a golfer out on the golf course asking Meta, how fast is the wind blowing in what direction? Number one. And it tells him. So, it will give you a description of the landscape, trees, sand, grass, distance, GPS, it all depends. It's not that accurate yet, but my point being is this. I'm meeting with him and having dinner with a friend of his by the name of Jake Olson. I don't know if anybody's ever heard of him. Jake is totally blind, and I'm trying to think here. He's been a commentator on ESPN's 30-30. And so, between those two, Jake had no idea about this until William told him about the Metas. It will probably really put this product on the map, not only in Florida, but throughout the country, because these guys will go absolutely crazy with what this can do in all aspects of their life, not just in their reading and their leisure, but in their life of golf and sports and whatever, because his organizations are really big. So, as you can tell, my passion is awesome in this. I love this field. I certainly hope if you all ever have a question, grab my card, give me a call. If you want to stop by, if you want to see these, you want to have them demonstrated, there's never a cost to that. And we're here to help. That's the bottom line. With all the partnerships we have with the eye doctors and the agencies, we're not going anywhere for a long time. So thank you for coming.
All right, I have a big enough mouth, so anyway, Bob had said that he doesn't know why I invited him back. I invited him back because he is a very reputable company. He doesn't come in, he doesn't force you to buy anything. I have dealt with companies in the past that have gone to people's houses, talked them into buying things that didn't work for them. He does not do that. If you buy something from him and you find it doesn't work, he'll come back and he'll make sure that you are happy. He will, even if he has to trade out product after product, he will find you something that will make your life easier. That is why I have him come back all the time. That is why the Macular Degeneration Association highly recommends him.
Oh,
And that's God's honest truth. Right now, I'd like to open the floor really quickly. If you have any questions for Dr. Cameron, Bob, Amanda, the Lighthouse for Pinellas, and Samsar, if you have any questions, they'll be glad to answer. Unfortunately, my mic went, so not a good video person. One last thing, please fill out your evaluation forms and hand them in to me. Very important, it helps me to keep developing these programs and to
know what you guys are looking for. Okay?
Thank you for that. Awesome.
Okay.
Yes, sir. Yes.